And request our MBMS National Webinar Coordinator, Professor Dr. Manish Tomar, to start this session. Thank you, and over to you, ma'am.
Thank you, Navneet. Very good evening, everybody, and very warm welcome, Dr. Radhakrishnan, Madam Dr. Snehal Kulkarni, and Amit from Sports Delhi is going to present his case. For me, this is like academic activity, means both of my teachers are here. I will listen to them and to test the maximum information, maximum knowledge from them. So, Amit, it's up to you. Let us start your case presentation now.
So should I start, ma'am?
Yes.
Good evening to all of you, ma'am. I'm going to present a 12-year-old male resident of Bihar, belonging to a lower socioeconomic class, student of class 6, who presented to us with a complaint of increased precordial activity since 2 months of age, easy fatigability since last 6 years, and palpitation since last 6 years. Should I proceed, ma'am?
Yes.
Yeah. Coming to the HOPI, child is symptomatic since infancy. I would like to start my history from birth itself. History was given by his grandmother and seems to me reliable. He was born to primary gravida with a term pregnancy by vaginal delivery. Cried immediately after birth with a birth weight of 2.4 kg. There was no history of any tachypnea or bluish discoloration in the immediate postnatal and in the natal period. Around 2 months of age, parents noticed increased precordial activity in the child, and they consulted local practitioner who advised them to consult a cardiologist, but parent didn't consult. Child apparently remained asymptomatic with no history of any tachypnea or any suck cycle or bluish discoloration or any kind of hospitalization till 2 years of age. Around 2 years of age, the child was again shown to a local practitioner in view of persistent cough, which was persisting beyond for more than around 10 days. Parents were told the child is having some abnormal heart sound and was again advised to consult a cardiologist. Cardiologist suggested for echocardiography and was given advice and was told that the child has a hole in the heart and was referred to higher center for further evaluation. But parent again didn't sought any further opinion. From 2 to 6 years of age, apparently no symptoms of tachypnea or any recurrent respiratory tract infection or any hospitalization, but parent do notice that the child was not gaining adequate weight compared to his peers. At around 6 years of age, child started developing symptoms of easy fatigability, which was insidious in onset and progressive in nature. Initially, he used to become fatigued while running or playing outside with the peers. Fatigability usually improves after with rest and taking rest for 10 to 15 minutes. However, the fatigability slowly progressed over a period of 6 years, and now the child becomes fatigued even while climbing one flight of stairs or walking around 100 to 150 meters. That is NYHA 3. Fatigability was not associated with the feeling of any dyspnea or paroxysmal nocturnal dyspnea, orthopnea, cough or expectoration, seasonal or diurnal variation or postural variation, any chest pain or giddiness. Child was shown with these complaints. The child was shown in AIIMS Delhi, where he underwent echocardiography and angiography, and parent was told that the child has hole in his heart and will need single stage surgery, and the date was given and was asked to arrange blood for the transfusion. Child was started on one medication which has increased his urine output. From 6 years onward, the child also started having symptoms of palpitation, which was persistent and was present even at rest. It was rapid and regular. gradual in onset and aggravated during exertion, and it was not associated with any post palpitation diuresis. Palpitation was not associated with any chest pain or giddiness or syncope. With these complaints, however, the child was according to the parent, the date of the surgery was given very long in the AIMS. So they had, so according to the parents, they have been advised to go for any private institution. So they again didn't turn up, and now they have presented with this complaint, ma'am.
Okay, just wanted to tell you a couple of things when before we start, when you try to present.
Yes,
I don't think this is a history which is required that they have been asked to go to a private hospital. This is not our concern in general when you present any kind of patients during examination.
yes, ma'am.
He was shown and advised something. He did. I don't think he wasn't given a date. He was asked to go to a private hospital. I don't think you should discuss all these things when you're presenting as a case in general. So, Radha, you have any comment on this?
No, it's okay. I mean, but then this is the stark reality. It is so
No, that's
unfortunate.
okay, but I think you are presenting a case, so I don't think these
That's
issues
okay.
should
I
be.
mean, it doesn't matter to me. Whatever.
matter.
But
Okay,
this
okay.
is the stark reality of our country. An unfortunate child has been diagnosed as CHD at 2 months of age. And
Yeah. Now, unnecessary, it should not take the discussion on some different lines. So it's better to avoid these points when you try to present.
Sure.
Okay. Now just tell me, I was just listening to a histories. A child who starts having a history from 2 months of age with a history of increased precordial activity. So what do you understand by this increased precordial activity at 2 months of age, and how do you analyze this symptom?
And this increased precordial activity actually tells about that the child has any means there is increased actually movement of the heart inside the chest cavity.
No. Now, what is the underlying hemodynamics going
Yes.
on when somebody has a increased precordial activity?
Means it's like palpitation like of activity. So there is
See,
What is the
palpitation
meaning of
is
increased precordial? What do you
increased
understand?
precordial activity
Which
in a
physiology we are
two-month child. What is the physiology? What is the underlying mechanism? See, the child won't complain about palpitation. Parents notice that
Yes.
there is increased precordial activity. So, what is happening inside so that the child can have increased precordial activity?
any kind of
What is the underlying thing? What is the underlying hemodynamic activity which is happening?
means ma'am there is increase in sinus tachycardia like situation, ma'am, probably.
Physiology. What physiology?
No. What is the increased precordial activity? See, every child, at 2 months of age, he cries also, he has a sinus tachycardia. So it doesn't mean he has an increased precordial activity. What is exactly happening? What is the underlying mechanism when increased precordial activity is noticed by the
Post tricuspid shunt or ma'am any regurgitation?
Basically, you are looking at something, there is significant ventricular dilatation
Yes, ma'am.
at this rate. And the dilatation can be mainly because of some intracardiac shunting which is happening.
Or because
And-
of regurgitant lesions, ma'am, also can.
Either because of a regurgitant lesion or because of a large shunt which is happening at the level of the ventricles or the great vessels. And therefore, there is an increased precordial activity.
Yes, ma'am.
So are you understood when you talk about that? You're talking about this underlying hemodynamic mechanism which is happening.
Yes, ma'am.
So from 2 years, the child is now 12 years. So this increased precordial activity is continuing from 2 years to 12 years.
Yes.
No, he said after 2 months he became asymptomatic till 2 years of age.
After
Yes.
Means for
Okay.
first
After-
year,
after
second year,
2
he
to
became asymptomatic.
he was asymptomatic by from 2 to 6 years, but except there was no weight gain. So what
Yes,
is happening here? Because for 2 months he has increased precordial activity and then he had no symptoms.
Yes. According to the parents, there apart from this.
I know, but there is no symptom from 2 to 6 years, except some no weight gain. There is no symptom. So
Yeah.
what is happening from increased precordial activity? Now there are no symptoms. So what is happening in this period? The child became right, the shunts closed, or what is happening?
Either, ma'am, the patient is developing some kind of pulmonary vascular obstructive disease, ma'am, or the size of the shunt is either decreasing. These two could be the possibility. So that
So according to you, either there is an increase in the pulmonary vascular resistance, so there is no effective shunting at all,
yes,
or the shunt size is decreasing.
side is decreasing.
What other anything else can happen so that the child has more symptoms?
More symptoms, ma'am.
Then now from 2 months again until 2 to 6 years, the child has no symptoms.
Yes,
So
ma'am.
what are the mechanisms why the
I
child
was saying
becomes
that
asymptomatic?
Anything small, could anything else be developing? One, you said pulmonary vascular disease, agreed. Then you said whole chota ho raha hai. Anything else can he be developing which can curtail the left to right shunt?
1, 2, 3, 4, 5. They are natural history.
So in general, when the effective pulmonary blood flow comes down, so they become asymptomatic.
Yes, ma'am.
So what else can happen so that effective pulmonary blood flow or QPQS comes down so the child is doing well? So one is good, like pulmonary vascular resistance develops, the child is better. The size of the shunt decreases, the child is better. What other mechanism can happen so that the shunt is less and the child is better?
Amit, standard questions hai yaar. Why can't you answer this? Nothing rocket science in this. Natural history pata ho to you can answer this. Somebody is trying to be smart there, wahan likh raha hai wo at the right hand corner.
Can there be some kind of a right ventricular outflow obstruction develop so that effective pulmonary blood flow comes down?
Yeah, I told ma'am gasolization phenomenon.
Okay, so either
Because of some obstruction in the RVOT, ma'am, the shunt is decreasing, ma'am. I told these two options only, and
total there in general, like we were discussing about 3. One is size of the shunt will come down, or ugly pulmonary vascular resistance develops, or effective pulmonary blood flow will come down because of the RVOT obstruction.
yes, yeah.
So which are the diseases where at 2 months of age somebody develops such a high pulmonary vascular disease that he becomes completely asymptomatic?
Completely asymptomatic.
Then he became relatively asymptomatic because suppose our theory is he has developed because there is something else happening, so that definitely the shunt has not become small because there is something else happening over the period of time. So suppose we assume that there is a high pulmonary vascular resistance and the shunt has come down. So
Yes.
what happens at 2 months of age? Which are the conditions where such a high PVRI can develop?
Ma'am, it could be some post-tricuspid shunt lesions only, ma'am, like AP window maybe there, ma'am, or it may be atrioventricular septal defect, ma'am. It could be, or like VST, ma'am, and yeah, or yeah,
More complex heart diseases.
Yes.
More complex heart diseases, which is likely to cause such high PVR at such a young age.
So it could be detransposed vessels with VSD.
How will they differ? Detransport, what else? Detranspose presenting with a large shunt. What are the complex lesions?
Cyanosis with increased pulmonary blood flow situation, sir.
Okay, anything,
Sorry?
see, usually it's little unlikely just you have a simple VSD and they will develop such a high pulmonary vascular resistance. I don't say it is not possible, it is unlikely. So we have to think of large shunts at a great vessel level or something very complex which is happening, cyanosis with increased pulmonary blood flow.
Yes.
There may be possibility that he has developed such a high pulmonary vascular resistance.
Yes, ma'am.
What about lesions like truncus and all? Obviously, cyanosis will not be apparent
This
at
will
such
not be
a young
evident,
age.
sir. Yeah.
Many
They
people
can,
might miss it.
yes, sir. Truncus can also present with very early, sir, with pulmonary vascular obstructive disease. Sir.
TGA, large VSD,
Yes,
these
sir.
have lesions which have the propensity to develop early pulmonary vascular disease. Although
Yes.
nobody has noticed any cyanosis at all, even till now, you have not made any mention of cyanosis.
There is.
Yeah, then now go ahead with the history. From 2 to 6 years, he had no symptoms. He was apparently well, according to you, isn't it?
Yes, ma'am.
And at 6 years, and now he has symptoms suggestive of easy fatigability. So, what is the symptoms of easy fatigability? Tell us what is happening underlying. What is the underlying hemodynamic mechanism for easy fatigability?
It basically suggests, ma'am, something. There is a low cardiac output state, ma'am, which
So, something which is a low cardiac output, which is happening at 6 years of age. And then he has undergone some studies, including cardiac catheterization and all, also, isn't it?
Yes, ma'am.
And he was told that he's operable,
Yeah, ma'am.
apparently, according to whatever it is. And he had again history suggestive of palpitations.
Yes, ma'am.
And now, what are the symptoms he has?
Yeah, ma'am. Only easy fatigability and palpitation. With these two symptoms, he is admitted, ma'am.
Now, how do you correlate all these things together? Now, what is like possibility in your mind when you see this patient? What is all happening? Because somebody who is symptomatic, no symptoms, then easy fatigability, and then has an angio, and again has increased precordial activity, easy fatigability, and palpitations.
Means, there is some shunt lesion, ma'am, which has actually the shunt has actually improved either because of any development in the pulmonary vascular obstructive disease or the shunt or the RVOT obstruction, because of which there is rather decreased cardiac output, and that is leading to the easy fatigability. And this palpitation is probably because of is because of only shunt lesion, ma'am, and this easy fatigability is probably because of development of this pulmonary vascular obstructive disease or the gasolization or RVOT obstruction.
Just about the negative history, which is important here. Can you, in this history, some of the negative history, which is will you ask, which is important?
Ma'am, this fatigability was not associated with any kind of dyspnea or paroxysmal nocturnal dyspnea or orthopnea or any kind of cough or expectoration or any chest pain or giddiness, ma'am.
Is there any history suggestive of syncope?
No, ma'am. There is no history of any syncope.
Is there any history suggestive of hemoptysis or anything?
No, ma'am. There is no history of any hemoptysis.
Suppose I assume that after 2 months, that's just suppose there is a large shunt which has become small in size, and that history is insignificant, and suddenly the child has this kind of a symptoms which started from 6 or 7 years of age of increased precordial activity, easy fatigability, and palpitation. Will you consider some other possibilities?
If there is recent any fever or something, ma'am, that can lead to infective endocarditis
No, what I mean to say, your 2 months had a history and he suddenly became better. I assume that there was a VSD which might have become small.
Yes,
and suddenly for last 4 or 5 years, he has this complaining of this precordial activity, fatigability, and palpitations. Can there be something else happening? Or you will like to consider any other possibility you want to?
Natural history of VSD. What next possibility?
Development of the aortic regurgitation could be there, ma'am, because of aortic cusp prolapse. That could be there.
That is one thing. Anything else you want to consider? Any other etiology of heart disease you want to consider? Because he has come from a low socio-economic class and all those things according to your history.
Non-structure
Anemia.
Anything else? Because that VSG may be there, is becoming small, it's not very significant, but something else is happening from 6-7 years of age till 12 years of age. So he's very symptomatic.
Develop nutritional anemia.
No. There's something which is very typical of these particular symptoms. What are these symptoms? Increased precordial activity, easy fatigability, palpitations. In fact, when you talk about the history, I was thinking of something else.
Pulmonary regurgitation.
With a child who has come from Bihar, from a low socioeconomic class, with these symptoms at 12 years of age. Any kind of acquired heart disease.
Sure. It could be rheumatic heart disease with mitral regurgitation.
So that's what I was asking. Maybe he has a problem in the beginning, which might have resolved on its own. We don't know. And these are the symptoms, whether it is an acquired heart disease, whether it's a rheumatic heart disease.
Yes, ma'am.
Which are the very typical some symptoms of what all you have been describing. Is it possibility, or have you looked from that angle? Like, did he have any history suggest?
Yeah, I have asked in the history, ma'am. There was no history of any prolonged fever or joint pain or ma'am rashes or prolonged regular IM antibiotics. I have asked specifically in the history, more in the past history, ma'am.
Okay, so you feel that whatever is happening is is a sequelae of what he was diagnosed as a congenital heart defect since beginning.
Yes, ma'am.
Okay. Anything, Radha?
No, I mean, I think we can now proceed with. He is now persisting with the same problem which has continued since 2 months of age. And all these possibilities are present. So let's go ahead and have the examination and see whether we can sort it out by clinical examination into which
Some part of the
category.
history is still there, sir.
Sorry?
So history is not, only the HOPI is complete, sir. Other part of the history is still.
Whatever it is, quick.
Okay, sir. So I have asked specifically for there is no past history of any bluish discoloration or cyanotic spell in infancy or squatting during the childhood. There is no history of any headache, double vision, vomiting, neck stiffness, convulsion or limb weakness. No history of any prolonged fever, hematuria, blackening of the fingers or prolonged IV antibiotics. There is no history of any joint pain, rashes or regular IM injections. No history of any abdominal distension or pedal edema. No history of any hoarseness of voice or dysphagia. No history of tuberculosis.
Okay, obviously you have thought of various angles, and in this, like Dr. Snehal asked, probably you have also thought about rheumatic fever or rheumatic heart disease.
Yes, sir.
But sometimes it is good to mention it, in a more direct way instead of somebody trying to force it out of you. So, okay, go ahead.
Maternal history, there is no history of any diabetes or hypertension in the mother. No history of any drug intake or fever with rash during the pregnancy.
With what relevance are you talking about diabetes in the mother, hypertension? Did you have anything in your thought?
Yeah, sir, TGA maybe means TGA may have an association with the diabetic mother, sir.
12 years of age, TGA.
They will not be surviving so long, sir.
Chalo, aage.
Okay, sir. There is no history of any significant.
Just to interrupt you for a second.
Yes,
What
sir.
is the typical history in the mother will be relevant to whatever is happening? Suppose you really have to ask the mother any particular drugs or anything which may go hand in hand with your history, which has a
Ma'am, there is an association of I think lithium injection for the skin, ma'am.
So maybe whatever you are talking about, the history since beginning, whether it has any relevance. Okay.
Personal history mixed Indian diet, blood and bowel habit is normal sleep pattern. There is no history of any consanguinity. One younger sister, no history of any congenital heart disease in the family. Lives in a pakka house with 3 rooms with separate kitchen and toilet, and belongs to the lower middle socioeconomic class, according to the modified Kuppuswamy scale. So to summarize, should I summarize now?
Yes.
So 12-year-old male child with history of increased precordial activity since 2 months of age, with no history of any recurrent respiratory tract infections or hospital admissions in infancy, was diagnosed to have congenital heart disease at 2 years of age, with poor weight gain in childhood, presented with the complaint of easy fatigability and persistent non-arrhythmic palpitations since 6 years of age, underwent cardiac catheterization at 6 years of age, and was advised for single-stage surgery.
Okay.
Should I go for the differential?
Yeah. And in your history, you said one certain thing which I was little curious. There was no history of post palpitation diuresis. You specifically mentioned that. So, any particular relevance to that?
Atrial fibrillation in case of if mitral stenosis, ma'am, they have an association with after AF, ma'am, there is this increased episode of urine post palpitation diuresis.
Only atrial fibrillation.
So, this you particularly mentioned that, so I wrote it. What is this phenomenon? Where do you see this especially?
Or any tachycardia that may.
Intermittent tachycardia, no?
Yeah.
Like PSVT.
Yes, PSVT can have this.
So have post palpitation diuresis.
Yes, sir.
Okay. So your possible kind of a diagnosis, or what are you thinking about?
Ma'am, I have kept the first possibility of cyanotic heart disease with increased pulmonary blood flow situation with post tricuspid shunt, ma'am, or VSD with RVOT obstruction like double chambered right ventricle, or any congenital regurgitant lesion like congenital MR or congenital AR, or Epstein anomaly with tricuspid regurgitation.
Okay, go ahead with
Last
it.
two क्यों add कर?
Yeah.
Surviving till
that I have kept in the last only, sir. That's why, because of
HA for 6 years. Do you think a primary PH will survive to this period?
Just the history that advised surgery and also primary PH.
Advice means advice surgery.
That's why I kept in the last only, sir.
No, not kept it at all.
But it doesn't come only actually. Yeah.
Natural history of a disease that should not have come at all there. Actually, there is no need for it to come at all.
Yeah. And then you said he is operable, he was advised to go for surgery, everything you said, isn't it?
Yeah.
And at 2 months of age, I don't think we can just label them as a persistent PH.
That was an unnecessary diagnosis. There was no need for that.
Okay, sir. Should I go ahead, ma'am?
Yes.
Coming to the general physical examination, the child was conscious, cooperative, well-oriented to time, place, and person, lying supine in bed. Anthropometry, weight was 25 kg, height was 140 centimeter, BMI of 12.8 kg per meter square, ma'am. The child was underweight with the arm span of 136 centimeter. There was no pallor, icterus, cyanosis, clubbing, edema or lymphadenopathy. Dentition is normal. There was precordial bulge on the left side of chest. Back and spine was normal. No evidence of any infective endocarditis or any evidence of acute rheumatic fever or marfanoid habitus, or no peripheral signs of aortic runoff. Coming to the vitals, ma'am, pulse rate was 98 per minute, regular, normal in volume, no special character, no radial delay or no radiofemoral delay. All peripheral pulses were palpable. Blood pressure in the right upper limb was 85, systolic 85, diastolic 66, and mean is 73. Right lower limb, it is systolic blood pressure is 98. Saturation is 94% in right upper limb and 95% in right lower limb. JVP, mean column of JVP is 7 centimeter above sternal angle of Louis at 45 degree. It is elevated, pulsatile, normal waves and descents, and normal respiratory variation. Child is febrile with temperature of 98.6 Fahrenheit. Coming to the CVS
With this blood pressure.
Sorry, ma'am.
You are happy with this blood pressure? 85 by 66 for a 12-year-old child. Pulse pressure of hardly 20. Very sick. Someone in ICU. This number you don't see in OPD for a 12-year-old child. You need to cross check by manual. This is no, it's not checked manually.
Yeah, systolic is on slightly on a lower side, ma'am.
Pulse pressure is 20. 20 pulse pressure is something very serious thing. Yes.
Narrow pulse pressure.
It says it is a sick, very sick, low cardiac output patient.
Low cardiac
in ICU. Okay.
CVS examination, inspection and palpation done together. Trachea appears central. There was precordial bulge on the left side. Apex beat was in the left 6th intercostal space, 2 centimeter lateral to the mid clavicular line. Forceful, and it was ill sustained, an LV type apex. Grade 1 parasternal lift. It was synchronous with the apex but not contiguous with the apex. There was palpable pulmonary artery impulse. There was no epigastric pulsation. Should I go ahead?
Yes.
On percussion, the liver dullness is in the right 5th intercostal space with the liver span of 9 centimeter. Stomach tympani was on the left side. Left hard border corresponds to the apex. Right hard border is retrosternal, and left and right second intercostal space is resonant.
You are saying something. You are saying P2, which is very loud. Then
P2 palpable pulmonary
there is a parasternal heave, and then you are saying the left second space is resonant.
Left one is ma'am dull, ma'am. Right one is resonant.
Left one is dull and right is resonant. Okay.
On auscultation, the S1 is normal. S2 is wide and variable with P2 equals to A2, ma'am. There is no S3.
Wide and variable. Wide and variable split.
Wide and variable split, ma'am. Yeah.
Okay.
P2 is equal to A2, ma'am. There is no S3 or S4 audible. No other added other sounds. Grade 3 by 6, low pitched rumbling, mid diastolic murmur without pre-systolic accentuation. Best heard in the left lateral position at apex with the bell of stethoscope, ma'am. And this grade 3 by 6, high pitched, harsh, crescendo, decrescendo, early peaking, ejection systolic murmur, not radiating to the carotid, best audible in the left second intercostal space by diaphragm or the stethoscope.
Okay.
On per abdomen, there is no hepatomegaly, ma'am, or no free fluid. Rest other system examinations seems to be normal.
Go back. Let's
Sorry.
Can you
talk about-
summarize your findings? Like positive findings.
Yeah, there is obvious cardiomegaly, ma'am.
Okay.
Cardiomegaly and this palpable pulmonary artery impulse with a second left intercostal space being dull, ma'am. And there is a wide and variable split S2 with PT equal to A2 and mid diastolic murmur and at the apex, and this ejection systolic murmur best at the second left ventricle.
This ejection systolic murmur,
Yes, sir.
grade 3/6 ejection murmur.
Yes,
at the
sir.
left second. Where do you think is the origin from?
It is most probably like because of increased flows across the pulmonary walls, sir.
Due to what?
Because of increased amount of shunt across the VSD or something.
Hearing the shunt murmur.
In a large VSD, suppose forget about this child, maybe a 6-month-old child, you have a very large VSD. Do you hear a ejection systolic murmur in any patient?
Yeah, I don't, especially with such severe pH. And
P2 is-
typically, if it's a post-tricuspid shunt,
And
you
sir,
don't hear these ejection systolic murmur, isn't it?
sir,
That's typically heard in pre-tricuspid shunts.
Yeah.
but P2 is still S2 is
And
still
then you
wide.
have a fixed variable split of the second heart sound.
Murmur of VSD, but
Yes.
there is a murmur of ejection murmur of high flow, but no murmur of VSD. How can that be possible? So obviously there is something wrong with your assessment of this systolic murmur. You have a diastolic murmur which indicates high flow.
High flow
which is
situation.
acceptable.
Obviously, shunt murmur was not appreciable.
Ever
Sir.
heard of an ejection murmur of a VSD as it been described? You can hear of an ASD, but not a VSD.
Just tell me, what are the murmurs you hear in a patient with just a large VSD left to right shunt with severe pulmonary hypertension, like maybe a 6-month-old child?
That's
What are the
what it
murmurs?
is. According to you, that's what it is. So, what are the murmurs you can hear?
What are the murmurs you hear in a large VSD when you don't have significant gradient across the VSD?
Will ma'am, one will be this ejection systolic murmur or and MDM murmur, ma'am.
So,
Ejection
no,
where?
I agree.
Ejection systolic murmur from where? कहीं से तो होना चाहिए ना.
Because of increased flow across the pulmonary
Have you
walls.
heard that? Has it been described?
No. If you are talking about a ejection systolic murmur, I will think that there is some obstruction to the pulmonary outflow, and therefore you are hearing the ejection systolic murmur. In just a large VSD, severe pH, you never hear a ejection systolic murmur at all. You, as Dr. Radhakrishnan said, you hear in a pre-tricuspid shunt, not in a post-tricuspid shunts. Do you feel even in large PDAs, in that particular theory, we have excessive pulmonary blood flow, so you hear a ejection systolic murmur in large PDAs also?
Not in PDA, ma'am.
But then why in VSD? With the same kind of a theory you are discussing.
It is only early peaking, ma'am, not so significant. So I don't.
No. You never hear a ejection systolic murmur across the pulmonary outflow tract in a large VSD. What you hear is only
You're saying it is harsh, crescendo, decrescendo. I mean, this is a significant murmur, isn't it? It is not now that you're saying, nahi, chota sa hai, some early peaking and all. According to your description, it's a significant murmur and it can only represent some sort of an RVOT obstruction.
Obstruction.
So are you talking like that? Is there RVOT obstruction? VSD large? Again, then you are talking about RVOT obstruction. You won't get a MDM at the apex mainly because your pulmonary outflow is restricted.
We won't find MDM in that case, ma'am.
Yeah, you won't find the MDM because you don't have that much of a QPQS to have a MDM at the apex. So how do you because on one side, and how do you explain your this the second heart sound, which is wide and variable split.
Yes, ma'am.
You have a wide and variable split, isn't it?
Yes, ma'am.
What happens in typical severe pulmonary hypertension, especially somebody is 12-year of age, who has a history of easy fatigability, and you may relate it to a severe pulmonary hypertension kind of a theory again at the end.
So P2 will be, I mean, that will be single S2 will be there, ma'am. And
So you have here, you have a wide and variable split,
yes,
but you have parasternal heave, you have severe pH, and then you have easy fatigability as a symptom, which again you want to correlate that with a significantly elevated PVRI, isn't it?
ma'am, only parasternal lift is there, ma'am. That is only grade 1, ma'am, not typically grade 3 parasternal heave. I like only.
Because something which is little not matching.
Most likely, Amit, what you're hearing is a very short systolic murmur, which is attributable to the VSD, which is still shunting left to right.
Yes.
Okay. You have converted this into an ejection murmur. So I think you should go back and listen to it whenever you get time, if you have the opportunity. Because this is a big mistake, I mean, your description about the systolic murmur is not compatible with your other features diagnosis.
So it is basically a mid-systolic murmur.
Yeah, but then you cannot describe the way you described it. It is clearly an ejection murmur arising from the right ventricular outflow tract.
Okay, sir.
Crescendo, decrescendo, typical description of an ejection murmur.
Okay.
You can have short
Basically mid-systolic murmur.
when you have a large VSD with significant pH, especially when the VSD is not very loud or it is silent, but still you can have a large flow situation.
Yeah, that is, I wanted to say, sir, that it is because of the flow across the. Sorry, sir.
See, immediately we caught on to you. But Snehal also quickly caught on to you. I mean, that description of the murmur is incompatible with your diagnosis.
See, don't make these kind of mistakes in the exam. In large VSDs, we don't have any outflow murmurs, just as a flow murmurs, what we see in ASD. So immediately we feel that, okay, this must be some right ventricular outflow tract obstruction must be happening. But on other side, you are talking about very loud P2, the history of easy fatigability. So it is not compatible with each other.
Yes, ma'am.
My own personal view is, Amit, you have overinterpreted this murmur which is present. I think this could be still a VSD murmur because it's all left to right shunt.
Yes, sir.
But because of the pH and all, the murmur must have been curtailed to a systolic murmur, not pan-systolic, not ejection systolic, but say early systolic murmur jo hote hain,
Yeah.
with VSD with still persistent large shunt, large VSD
Yeah,
pH.
Yes, yes, sir. I just wanted to, actually it's a flow murmur I wanted to tell, that's it.
वो मर्मर तो बता दिया ना अमित और
Yeah.
कौन सी मर्मर होती है VSD में that is where we are trying to point out your mistake. In VSD you will not have a flow murmur from the pulmonary valve.
Yes.
Typically you have this with a pre-tricuspid shunt, and that's the mistake which we are trying to point out to you. तुम बार बार उसको flow murmur कह रहे हो. You don't hear flow murmurs from VSD, from the pulmonary valve.
Yes, sir. No, we don't.
Okay. Now you have a X-ray and ECG.
No, I don't have, ma'am. Sir,
I have it, Snehal. Shall we go ahead? Can you make a diagnosis first of all?
Can you make some like a preliminary diagnosis with it?
Your complete diagnosis, please. and then we quickly move on to the other things.
It is situs solutus.
Can you
Levo-
show it to us?
Sorry, sir.
Can you show that diagnosis which you have written?
No, I have not written, sir. I'm
Your
just,
final diagnosis, please.
yes, I'm just telling, sir. Situs solutus.
Yes, please show it to us. We have been telling you repeatedly, please write it down. What is your final diagnosis? Because we want to point out mistakes if there is any in your final diagnosis. Why didn't you write it down? You had enough time. Go ahead, let us know what your अब तो ये सब you made up होता है ना कि ये भी याद आ गया वो भी याद आ गया. Go ahead.
Situs solutus levocardia, sir, or cyanotic congenital heart disease with increased pulmonary blood flow situation, post-tricuspid shunt lesion, post-tricuspid shunt lesion, VST, with increased QPY/QS of more than 2:1, and no evidence of any.
वो ऐसे ही होता है. You speak nonsense, जब लिख के नहीं रखते हो तो. What pH is this? pH है या नहीं?
Yes, sir, है.
So what sort of pH is this?
So moderate pH, sir.
Moderate pH. Your P2 is palpable in the second left intercostal space. अभी भी moderate ही कह रहे हो. And when I asked you what sort of pH is this, I didn't mean that.
So P2 is not palpable, sir.
There are types of pH, isn't it? Especially with congenital heart disease, post-tricuspid shunt. That is what I want you to tell us with your clinical findings.
Get the question? Shunt lesion, type of pH.
Oh, hyperkinetic pH, ma'am. This one.
तो इसीलिए होता है ना क्योंकि तुम लोग लिखते नहीं हो. सब कुछ लिख लिया, उसका BMI लिख लिया, वो लिख लिया, but final diagnosis नहीं लिखा. You are leaving it to us to make that diagnosis.
No.
बच्ची मदर को डायबिटीज नहीं है, ये नहीं है, लेकिन फाइनल डायग्नोसिस नहीं लिखा. यू विल नेवर पास. यू कैन आस्क नेहल और मुनेश if you make such gross mistakes. Ask Snehal से पूछ लो. Final diagnosis is so important based on your clinical finding, and that is where we point out these mistakes. छोटे छोटे मिस्टेक्स हैं, ये नहीं होना चाहिए, ये होना चाहिए, और तुमने लिखा ही नहीं है उसको. Shall we go ahead, Snehal?
Yeah, Amit, how often you see somebody has a very large shunt at 2 months of age, and you feel that at 12 years of age also it remains as a hyperkinetic pH?
Yeah, so this is so unusual, but then we have seen it at the age of 20 years also. There is no
Can you
explanation.
think something like it can be some kind of yeah. Is there some possibility of congenital mitral stenosis, which was moderate, and then the child has overgrown, and you are hearing all these things?
Very
And
unusual.
then what is the pulmonary hypertension also becomes very important there.
Congenital mitral stenosis, ma'am.
Huh?
But
क्यों
there
तुम
is
तो diastolic murmur कह रहे हो?
Diastolic murmur है, तुम्हारा systolic murmur also will maybe a tricuspid regurgitation murmur. It's not ejection, but a pansystolic murmur. There is a pulmonary hypertension. There is a easy fatigability. There is a palpitation. Everything is there.
S1 is not loud, ma'am, here. Oh.
Hmm.
Uh,
How often in congenital mitral stenosis we hear S1? Why do you get S1 normal or S1 not very loud? What does it depend upon?
That depends on ma'am, actually whether the valve is calcified or not, ma'am. So,
Valve is pliable or not pliable?
yeah.
If the valve is pliable, you may hear a normal S1. I'm just asking you, if you are thinking, are you thinking of some other possibilities with your MDM is the prominent murmur there?
And there is no also
The parasternal heave.
but there is no pre-systolic accentuation here, ma'am, which should have been there with the mitral stenosis.
No, Amit, please try to understand. Have you thought about this? That is what Snehal is asking.
I'm just
She's
asking
not
that
saying it's mitral stenosis hai. Did that thought ever come to your mind that ऐसे भी हो सकता है because इतना severe PH है, but at the same time you are attributing this mid-diastolic murmur to a flow murmur. Have you thought about other possibility? That is what she
I'm
wants
just
to.
thinking, yeah, any other possibilities are you thinking about
Out of the
something?
box, so to speak,
Actually, I have
ऐसा लड़का है, severe PH है, but yet you are hearing a low-pitched mid-diastolic murmur at the apex. That's what she wants to know. She's not saying you have missed mitral stenosis. You understand what she is implying?
Yes, ma'am. There could be this could be the possibility, ma'am. Congenital MS, obviously.
Congenital or acquired, because history of rheumatic is not
Yeah,
fine. Hardly 50% of the patient will get the history.
yeah, only 40% of the patient usually give history of rheumatic fever, ma'am.
So that DD which plan started should continue.
Congenital myas.
Another thing I would have liked you to say is congenital mitral stenosis does not exist in isolation in general. It becomes a part of a Schwann's complex. So you may get some other associated obstructive lesions if something has started from the neonatal or life or early infancy. You don't have any evidence of that.
Okay.
Again, usually if it is severe, the child would not have been asymptomatic between 2 to 6 years of age. It's very unlikely because we have not discussed that part. Again, with a large PhD, why he was asymptomatic during that period, it's very unlikely. He would have been progressively symptomatic if the history doesn't fit into that particular thing, and we don't have any other associated lesions like other LVOT obstructions.
LVOT obstruction, supra. Yeah, with coarctation or something.
So it's unlikely because I was just trying to understand what are your thinking processes.
Can we go ahead with the other one?
Yes, yeah.
So, can you see this? I don't know. This was given to me. Are you able to see this?
No, sir. You need to share your screen is not. It's only Amit is.
Otherwise, if he is with you and he can like talk, it's okay. We are not able to see.
तो कैसे करेंगे मुने? Shall I send it to you by mail?
You can send it to Amit and he will share. He can share from his side.
To Amit?
Ah.
Okay. So we should have done this before. I'm sorry. Okay, I'm just sending it to Amit. In 1 second, you will receive it. Amit, can you hear me?
Yes, sir. I'm just opening my mail, sir. Yes.
What is this thing? Email address? Amit?
Of PMCH at gmail.com, sir.
Amit?
OF.
AMITOF.
Yes, sir. P for parrot.
Amit OF.
PMC. Yes,
at
gmail.com. Gmail.com, sir. Yes.
Okay. I'm sending it. The message has gone. Amit?
Yes, I have opened, sir.
Okay.
I have not received so far.
Text your mail to sir just for spelling check.
Yeah. Should I write somewhere, ma'am?
You can write on your slide, sir. यहाँ से copy मतलब we'll see from or text to sir.
Otherwise, send by WhatsApp, Manish. Radha,
हैं?
send by WhatsApp, he will receive it faster.
Am I?
नहीं, मेरी तरफ से तो चला गया है.
Sir, spelling तो एक बार check कर लीजिए. ये this is on this screen.
Sorry. Amit, have you received it?
No, sir.
Hello?
No, sir. No, sir. Yes, sir. Now I have received.
आ गया?
Yes, sir. Yes.
हैं?
Yes, sir.
Now I have gone out of WebEx now. मेरा कहाँ चला गया?
नहीं, you are visible, sir. वो नीचे minimize होगा.
There is an icon in black square inside like a DNA at the bottom.
Okay.
Yeah. We are able to see your now ECG and everything.
This is now through Amit.
Yeah. Yes, sir. I'm trying to share it, sir.
No, but we are able to see the
We can
ECG.
see.
You can see
We are
it.
seeing
Why do you want to share it?
Okay.
We are able to see the screen.
Okay. So, this is 4-channel, 12-lead ECG with heart rate of around 70, 60, between 65 to 70 per minute. And this with normal standardization, ma'am, of the chest limb leads and the chest leads, and P axis appears to be normal, ma'am, between 30 to 60.
Sinus rhythm, the first thing, sinus rhythm,
Yeah,
Now talk about rate, rhythm, sinus rhythm.
yeah, it's sinus rhythm, ma'am.
Heart rate, you said 60, 70.
No.
What heart rate you said?
Wait, ma'am. 3
Rate, rhythm, like a preliminary things, QRS axis, P wave axis, chamber enlargement. Like there is a format how you describe a ECG in general and specifically in the examination.
It was somewhere around 90, ma'am.
It's a 10, no? It's around 125
Yeah.
to more than that.
300 divided by last 3 boxes, ma'am. So
Around 100 to 120, some 100 plus. Okay. Sinus rhythm.
Sinus rhythm, ma'am. And QRS axis is, I think, AVF is seems to be, I don't know exactly, ma'am. There is overlapping of
AVF are negative.
AVF is slightly positive looking. AVF.
First of all, loop in this.
Sorry, sir.
Is it clockwise loop or a counterclockwise loop, and in which quadrant is the axis?
Yes, I'm telling, sir. One.
So there is a Q in 1 and AVL. So which is a clockwise, anti-clockwise?
Ma'am, this is counterclockwise, ma'am.
So counterclockwise loop. Your axis is in the. Therefore, I thought like it's a 2, 3 AVF are negative. So what is the axis? Which loop it is in?
Seems to me, ma'am, it's somewhere around more prominent in the lead 2. So somewhere around 50. I think, ma'am, AVF seems to be equiphagic, ma'am. So I think it's in around 0 degree or something.
Or even minus that.
Yeah.
Even AVF is a little 2, 3 AVF are negative. There is a counterclockwise loop. Suppose it's a VSD. What kind of a VSD you think about?
Inlet VSD, ma'am.
Yeah, it's a kind of, it tells you about there is something happening in the inlet septum.
Yes, ma'am. And then there is RSR pattern in the V1, ma'am. With and there is a LA enlargement also, ma'am, because of negative deflections in the V1. So LA seems to be enlarged, ma'am. There is no RA enlargement. There is normal progression of the R wave in the chest leads, ma'am, suggesting levocardia. And there is wide ma'am, almost equiphagic means biphagic waves, ma'am, that is like more like a Katz-Fitzgerald like phenomenon. And there is a deep Q waves in the V5 and V6, ma'am, suggesting of LV volume overload conditions.
So what is happening? What are the positive findings in this ECG?
Seems to be like, ma'am, biventricular hypertrophy and with still overloaded LV, ma'am.
See, if we expect there is a counterclockwise loop, there is a possibility of axis which is negative, like maybe less than minus less than 0. Then there is a biventricular hypertrophy. There are deep Q waves in the lateral lead, suggesting that there is a volume overload of the ventricles.
Yes, ma'am.
So, what kind of like a diagnosis which can come with this kind of ECG findings?
Means post tricuspid shunt lesions, ma'am. Most likely, yes, sir.
Clockwise loop. What are the things that comes to your mind? That is the question Dr. Snehal is trying to ask.
Atrioventricular septal defects, sir, with increased shunt, sir, means
we are talking about a counterclockwise loop in a congenital heart disease with other features, biventricular hypertrophy, ye wo sab hai. Like you said, AV canal defects will have a counterclockwise loop, isn't it? Or
yes,
kaun si lesions that come to your mind? Nothing else? She just told you, अभी तो स्नेहल ने हिंट दिया था तुमको. VSD situated in unusual places.
Inlet VSD.
हाँ तो वही तो पूछ रहे, वही तो स्नेहल ने तुमको हिंट दिया ना. और lesions हैं जिसमें काउंटर क्लॉकवाइज लूप होती है.
लूप आता है. परलॉक. What other lesions?
Ma'am, primum AST, not in this case, ma'am, primum AST, that could have this.
Chalo, you read about it. Go ahead. Shall we move on to the next? X-ray?
Yeah. X-ray.
It's not a common garden. It doesn't appear to be.
Somebody has written here tricuspid atresia. Here somebody has written suddenly as a tricuspid atresia when you have do you agree to that? Somebody has written here tricuspid atresia when you have. I mean, some of your friend has written tricuspid atresia here.
Should be well developed, but इसमें तो RV में अच्छा forces आ रहे हैं.
अच्छा forces of right ventricle. That's what. P waves are normal. There are no. Yeah, RV is very well developed. You see the V4, V3, V4, V5.
Biventricular hypertrophy.
Biventricular hypertrophy.
Yeah. Suddenly I saw that, and somebody has written, "Don't make this kind of mistakes in the exams." Somebody has written even PDA pulmonary hypertension. Again, it just don't. The ECG doesn't go only with a PDA. Just is a biventricular hypertrophy, but your counterclockwise loop and all doesn't go just with a PDA. Okay, X-ray.
Can double outlet right ventricle?
Yeah, even it's a double outlet right ventricle. I was just thinking that counterclockwise loop. In fact, in a VSD, we just see that whether it is a D or V because that differentiates again. against this other DSP
have
with
all
the DORB.
sorts of ECG.
Yes,
All
DORB have
इसमें
all
आता
sorts.
है।
Yeah, that could be the possibility, sir.
चलिए एक्सरे देखते हैं।
This is chest X-ray PA view, sir, with situs solitus levocardia, with looks to be cardiomegaly, sir. Cardiomegaly is still cardiomegaly present with
अमित ऐसे एक्सरे देखोगे तो व्हाट इज योर फर्स्ट इंप्रेशन?
this oligemic lung field, sir, with
ओलिगेमिक
not oligemic, sir. Pulmonary artery prominence, main pulmonary artery prominence is very prominent, sir.
Huge.
दिस इज लाइक एन आइजनमेंगर एक्सरे नहीं?
Yeah, it's like an Eisenmenger. Just see
मेन
the
पल्मोनरी
main pulmonary artery, peripheral
Right
vascularity.
descending arteries with peripheral pruning is also there, ma'am, in the right.
This is classic. LA is not enlarged.
Yeah, this LA is not enlarged, sir.
अब वही तो कह रहा हूँ
ECG
ना।
LA was not enlarged. He said in ECG LA is enlarged.
Yeah.
So hardly any.
I mean, we are not trying to find fault with you. I mean, these are different investigative modality. But then, for a 12-year-old, this is classic Eisenmenger X-ray, isn't it?
Classical Eisenmenger's X-ray. See the pulmonary artery prominence,
Very
hilar prominence, and see the peripheral vascularity.
Somebody has chopped it off, pulmonary artery.
It's a very
So-
classic of
There are
Eisenmenger.
certain discrepancies.
Yeah, only thing the heart size is still little bigger than what we see otherwise in Eisenmenger's.
cardiomegaly
Between
is
your
still there.
clinical finding and the X-ray, there is some discrepancy,
Hmm.
Okay, next.
See, X-ray only, sir.
No, let's go on. Now quickly start talking about the echo.
This subcostal transverse view showing seems to be
बोलते जाओ.
Yeah.
I mean, these are not very good echo images, but then ये सब क्या दिखा रहे हैं अमित? जल्दी बताओ.
sir, IVC and sir,
Just tell us the diagnosis.
situs solitus, sir.
Good. Move ahead. Next. Which confirms your finding also. Okay. Next.
This subcostal coronal view, sir, showing LA, LV, and RA and RV, sir.
What is the promising thing this view tells you?
Ma'am, still LA is in seems to be
Large. So that's one of the
LA
promising
enlarged.
things it tells us.
Yeah.
And a mitral valve is normal.
Yeah,
There were some thoughts arising about mitral stenosis. But what is very striking in this thing, here we are talking about severe pulmonary hypertension, large VSD. What does this view show you? I mean, it is encouraging also, but at the same time, it is so, what you call glaring.
So there is dilation of the LA and LV, sir.
हाँ वो तो बोल दिया.
And
But on the other side, you don't see the significant dilatation of the right ventricle also in this view.
Absolutely. It's
That
all
is actually, yeah.
It's all LALV. That's all in this view. Doesn't that look striking to you? RV is ऐसे
RV
पिछड़ा हुआ लग रहा है कोने में.
yeah, RVH should have been there prominently, sir.
Very big pulmonary vein is
RV and RVH. Please don't confuse the. RVH तो है ही, उसमें क्या doubt है? Typically, in an Eisenmengerized echo, you don't see LV so prominent. Na?
LV should have
see
been
RV prominent.
Yeah, RV prominent, sir.
These are things which strike you. तुम लोगों ने इतने सारे echoes देख चुके हो अपने life में. I mean, this is the first thing that should strike you. Okay, go ahead. Next. ये क्या तुमको स्ट्राइक करता है इस इको में?
There is good amount of pulmonary venous return, sir.
Yes. All these are so-called encouraging signs,
Yes,
Chaliye,
sir.
next.
Yes,
Apologize for these images, the best one. Batao.
there is subaortic VST, sir, and LV is contracting normally, sir.
What else? कुछ great vessel दिख रहे हैं?
One vessel is arising, sir.
Okay, you're not sure about it. So let's
Yes.
move ahead. So there is a large VST that is very clear.
Yes, sir. And there is a left to right, predominantly left to right shunting is there, sir.
Okay, you should keep it at the back of your mind. Don't commit too much till you see the whole thing.
Okay, sir.
Okay, go ahead.
This is a apical four-chamber view, sir. Showing again LV is enlarged, and there is RV hypertrophy also, sir. And
we were discussing about some type of VST. Snehal was mentioning.
There is no inlet VST. Seems to be no inlet
VST. Okay, next.
There is a trace of mitral regurgitation, sir, and there is normal inflow across mitral valve, and slight means right sided there is tricuspid regurgitation also, sir.
Okay, go ahead. Next.
This is again showing the VST. Sorry, sir.
अब बताओ क्या है इसमें?
There is perimembranous VST, sir, and other.
तुमने पहले बोला subaortic VSD, अब कह रहे हो perimembranous VSD है. There has to be some consistency in your nomenclature, ne? We don't use the word subaortic VSD nowadays. Snehal, do you use it?
Yeah, no, actually, these kind of VSDs, when we see some kind of a ponotruncal abnormality, then only this relationship with the VSD and the great artery comes in the picture. Otherwise, you
consistent in your this thing.
Perimembranous VST, sir, we like to say.
Okay, you're saying it's a perimembranous VST.
Yes, sir.
What else do you see? It is so grossly seen.
Great comment on the great vessel.
Oh, lo, bata diya mane.
I'm just trying to appreciate which vessel it is there. That is.
But
क्या वेसल होगा? हमें तुम ये बताओ इसमें.
Sir,
तुम्हारी
it will be aorta only, sir.
95% saturation है.
It will be aorta only.
हो सकता है वो?
Aorta.
एओर्टा ही होगा ना. और
Yes,
अगर
sir.
एओर्टा है तो क्या है डायग्नोसिस?
But perimembranous VST.
डॉक्टर साहब कितनी ओवरराइड है उसमें दिख रही है आपको?
Yes,
ओवरराइड दिख रही है.
more than 90% is there, sir.
तो क्या डायग्नोसिस हुआ?
Double outlet right ventricle.
Good. So that could partly explain your ECG finding. I mean, I'm just.
Yes,
Yeah.
yes, sir.
Yes.
Okay, go ahead. Next, क्या है?
The flow across through the VSD, sir, and means that the aorta is filling only through the right ventricle and then not directly. and there is
a bidirectional shunt.
yeah, but looks like bidirectional here. There is a trace of AR, I think.
Next. Next.
Yes, sir. This is subcostal, no, sorry, short axis view at the great vessel level, sir. Showing a large perimembranous VST.
Think about it, Amit. ऐसे ही मत बोलो, ढंग से देखो उसको.
Where is the VSD? Can you just see this? You are seeing both the semilunar walls.
Yes, ma'am. Here one and the another one here. So
Already,
there
Sneha has given you
there
the
is a
hint.
fibrous tissue here, sir. So it can't be doubly committed. So it's more like a perimembranous with outlet. Yes, sir.
It doubly committed. You can see the aortic valve and pulmonary
Yes.
valve. in
Yes.
continuity.
So it's more like a doubly committed VSD actually. It
Absolutely.
looks like from the echo.
Oh, but
Next वाले में देखना.
okay. And there is usually dilated this pulmonary artery, sir.
हाँ.
With maybe
इसमें सारा left to right shunt.
Sub left right.
right
shunt.
predominantly, sir.
This is a much better view. The flow is, like we would want it. अब देखो ये VSD को.
Yeah, there is no tissue between the aortic and the pulmonary valve, sir.
Both
So
the
it
aortic
is
valve
beautiful,
and
like
pulmonary valve
Yeah.
in continuity.
yes, so in continuity, so doubly committed, or if it doubly committed, sir.
And aortic valve?
Looks like bicuspid or something.
Yeah, it looks like a bicuspid aortic only.
Yes. Do we have time to discuss anything?
So we are already 15 minutes.
Yes, I understand that.
We can,
That's why we-
Navneet, can we take 10 minutes more?
This is
I just
parasternal.
want to show him the hemodynamics.
Yes, sir, we'll take 5 minutes. I think he's.
Okay,
Parasternal.
thank you. You can now even see the 90% override.
Yes, sir. Parasternal long axis view showing
What you
90%
don't see is the aortomitral discontinuity,
नहीं,
which is slightly unusual. But Anderson keeps on saying this, no?
yes, sir.
Yeah. But there is I do agree that there is a mitral aortic continuity. It's not like a
Continuity.
discontinuity because I don't see any conal tissue. And the second one is if you have a conal tissue, your aorta pulmonary artery relationship in the thoracic cavity, as we see in the parasternal short axis view, is maintained.
Hmm.
So therefore, there is no conal tissue.
Chalo, next.
But the aortic, yeah.
This is the flow across through the VST, sir.
I
And,
mean, with
I say-
VSD, you can always have bidirectional shunt. What is important is the next. Chalo, आगे बढ़ो because time is running out.
Yeah.
so all based. This is the
Arch normal है. चलो next.
CAT has been done.
okay. So,
सब
Yes.
कुछ है इसमें. अनफॉर्चुनेटली तुमको कुछ कैलकुलेट नहीं करना है.
yes, sir.
The resting PVR is 7.8.
7.8, sir, which is elevated, sir. And RP by RS ratio is 0.5, sir.
So all this is very discouraging, isn't it?
Yes, sir.
And the resting QPQS is just 1.4.
1 point. Yes, ma'am. So coming to the saturation part, should I elaborate, ma'am?
No. I think this is enough. QPQS, PVRI, RPRS ratio.
Pulmonary
Next.
pulmonary vein saturation is still means there is no lung pathology, at least 96%. And LVEDP is normal, and RA mean pressure is also normal.
So what doesn't fit into your clinical finding? You said something, your JVP is raised till 7, but
Yes.
इसमें तो RA pressure, although they are different
normal,
meanings.
sir.
ठीक है. So I think he was given sildenafil plus a combination of oxygen.
And PVR has fallen down to 2.6 and RPRS ratio of
What is
0.1.
the biggest objection to this sort of cath data?
Sorry, sir.
Your major objection to this form of cath data जिसमें oxygen दिया जाता है, people have generally stopped giving oxygen as a vasodilator for cardiac cath studies. And what is the issue?
Why oxygen is not being used nowadays for doing the cardiac catheterization for operability issues?
बाहर use करते हैं, but they have their own facilities and all, which I have yet to see that instrument in my lifetime. I don't know, Snehal must have seen.
What did you say, Radha?
मैंने वो इंस्ट्रूमेंट को देखा ही नहीं है अपने लाइफ टाइम में,
क्या इंस्ट्रूमेंट को
जिसके ऑक्सीजन देने के बाद जो करते हैं. आई वांट अमित टू आंसर दैट क्वेश्चन.
अच्छा. Okay. What does oxygen does to the pulmonary vascular resistance and the systemic vascular resistance, Amit?
Ma'am, oxygen will cause pulmonary vasodilation to the pulmonary vasodilation, ma'am.
And what does it do to the systemic vascular resistance? It elevates systemic vascular resistance. It decreases pulmonary vascular resistance. So you have a lot of fallacies when you have use oxygen for your operability issues. Fortunately, here the pulmonary vein saturations are normal. But if your pulmonary veins are desaturated and you have any lung issue, you're giving oxygen will make that 100%. That will again screw up your data completely.
Plus the fact that our oxygen consumption and all will all go haywire. Absolutely.
So how to explain the subsystemic PA pressure post oxygen? Once we expect diastolic, but here PA pressure systolic is also significantly low after oxygen.
Yes.
I don't know how this PA pressure has fallen so much.
Because this is typical VOR is such a huge VSD, so some
and especially if you have a subarterial VSDs, they are known to develop elevated PVRI very early in their life, as compared to you have other VSDs.
Yes.
No, what Munesh is pointing out is one can expect diastolic pressures to fall, but why should the PA systolic pressure fall?
Yeah. It's
probably catheter means mechanical issue there, catheter trap or something. Yes. This echo we can't.
And therefore the PVR is significantly fallen down because the PA pressures have come down. The systolic PA come down,
Yeah, it cannot with such a large VSD.
No. Because looking at the X-ray itself, I thought he may not be operable.
I think so. So, Amit, you have to point out these discrepancy. I don't know where this was done. I'm not sure.
Yeah, but before we take a decision for operability, I think we may need to recatheterize the patient.
Yes, absolutely.
Okay.
So,
what will you do, Amit? What is the possibility? I mean, what are the thoughts that come to your mind as a consultant?
Systemic
See, your resting data is not encouraging, isn't it?
Yes, sir.
I mean, ये ऑक्सीजन देना, फिर दिस सॉर्ट ऑफ अ प्रेशर इस तरह गिरना, आई थिंक आई विल इग्नोर दिस फाइंडिंग. ये जो है ऐसा स्नेहल ऐसा, आई थिंक अगर करना ही है तो फिर से कैथ करना चाहिए इसका. How can
And when you are, yeah, always this Dr. Kothari says, when you are in doubt regarding operability, it's always better not to operate. Yeah, because the X-ray is absolutely discouraging.
X-ray and H.
एक और ये होगा देखना, LV Z-score was plus 3.6 or something. Anyway, I think you have to do a
We have
recap.
to recap to study really whether he's operating.
Because this is grossly, this is not possible that the PA pressure becomes half systemic on sildenafil, especially systolic pressure, you know.
Yeah. Okay.
Okay.
Thank you, Manish.
Thank you, ma'am. Thank you, sir. And thank you, Amit. Just need to present more cases. And
With more confidence
yeah, with
and
more
clarity
confidence.
in thoughts, you know, what you want to say.
Yes.
Thank
So, best of luck for your exam. It's very close. And thank you, everybody.
Thank you.
Thank you, Manish. Thank you, Snail. Nice meeting you people.
Thank you very much, Dr. Amit,
Thank you, sir.
for the presentation. And thank you very much, Dr. Radhakrishnan and Dr. Manish Tomar for joining us.
Thank you.
And thank you, trainees, for joining us.
Bye.
Thank you.
Thank you.